It is my pleasure to welcome you to our 6th Leadership Forum. Our last forum in 2010 had the theme Oral Care 2025 and examined innovations in delivery systems, financial support, technology, and workforce, and how they may play out. The effect of all of this on the provider-consumer was examined in detail. Oral health and overall health integration as a way of adding value to oral care was just beginning to be discussed. Our previous forums tended to involve speakers from the dental community, addressing an audience from the dental community. For this year's forum, we asked ourselves, why not have people from outside the world of dentistry address an audience of influences from outside our community? The Harvard School of Dental Medicine was 147 years old in July. It was the first dental school in America associated with its university and medical school. The philosophy that dentistry is a branch of medicine directs our education and practice. In fact, our mission is to develop and foster a community of global leaders dedicated to improving human health by integrating dentistry and medicine at the forefront of education, research, and practice. Our vision is to transform dentistry by removing the distinction between oral and systemic health. Consistent with this mission and vision, the program today and tomorrow, Put Your Money Where Your Mouth Is, the economic imperative of oral health, will explore the costly impact of poor oral health on overall health, especially chronic disease.
Well, about 130 million Americans, or 43% of our population, have no dental insurance. Some 80% of the nation's practicing dentists do not accept Medicaid. And of the 20% who do, more than 1/4 of them devote a substantial part of their practice to serving the poor, or chronically ill, or rural residents. So we need to improve state and federal Medicaid reimbursement policies for dental care, but we must do more than that. The successful implementation of the Affordable Care Act will bring up to 32 million Americans into the health system. That is a good thing and will ultimately improve the health of our nation. But it demands that we produce more well-trained health professionals of all kinds, physicians, dentists, pharmacists, public health professionals, and others. And we also must find ways to deliver care in new ways and in more places. First, we need more dentists. Currently, the Health Resources and Services Administration indicates that we need today some 7,300 more dental providers in order to meet our current needs for oral health care. We need to increase the diversity of our dental workforce. Less than 6% of our dentists come from ethnic or racial minority populations. And although some 35% of our citizens are African Americans, Hispanic American, and Native Americans, we have too few of these populations represented among our dental professionals. Training new dentists takes time, and we hope that when trained, these new dentists will practice in areas of need. And while we can expect these new dentists to bring passion for their profession and the responsibility to care for their fellow citizens to their task, what is their incentive to locate their practices in dental health profession shortage areas? So we must consider new models of care if we are to meet the oral health needs of our citizens.
So, what do we know? Well, I want to talk about clinical trials, what we know from insurance databases, and where we are now, so we can set the scene for our wonderful panel we're going to have. Some studies show that integrating oral health with overall health will lower overall insurance costs. Now, if you get one study to show you anything, you say maybe, right? We all say maybe. Even if we say nice things to the author, we still say maybe. So let's see where we are. Why are insurance studies important?
I'd like to thank the organizers of this program to be here today and talk about some of the research that we have going at Blue Cross and Life and Specialty Ventures linking oral and overall health. I'm a periodontist. I was trained here at Harvard and at the VA many years ago, and I still have a practice. I still practice 1 day a week, and I practice just a few miles from here. And I was in practice this morning, and on the way out, I was seeing a patient that I had seen for many years. He's actually a diabetic patient, and he comes in for cleanings on a regular basis, and he's very well maintained. And what we usually do is, talk a little bit, and I told him I was coming over here this afternoon and what the topic was going to be about. And he said, tell them that these 4 cleanings a year that I get are really helping my diabetes. So I'm here to tell you that 4 cleanings that he's getting a year are helping his diabetes. And I thought about that on the way over. And I said, if we could get every patient to just say something like that, that would mean 2 things. One is the patient understands that there's a connection between oral health and the medical condition, and B, they're motivated enough to do something about it. And if we could do that, our problem would be solved. But up to now, I think we've been making attempts. I think we've made good progress, but we're not there.
As an organizational behavior scholar, as a sociologist, I want to frame this as a subject of change, which is, I think, what the topic is, which is, and the way that we often think about change, it sort of falls in scholarship around 3 buckets. So one is you change structures and systems, or what we would just call shoving. This is like incentives, rules, carrots and sticks, provisions of resources, subsidize the kinds of behaviors that you want to see, and increase the penalties on the kinds of behaviors that you don't want to see. And I think in the context of healthcare, dental healthcare not being any different, which is things like, how much do you pay? How much do you subsidize? Do you provide incentives for people to undertake certain kinds of behavior? A second approach, which is slightly less coercive than shoving people, is changing people's choices and decision-making framework, or what's often popularly known as nudges. And here, behavioral psychology, economic sociology is often helpful. It is often focused on changing the choice architecture so that people's default views or default incentives move. There's one set of reasoning that focuses on the pitfalls that people who don't have time to think about things carefully to correct the reasoning that leads them to make poor decisions. That is, decisions that are probably in their best interest if they were fully informed, or had the time to become fully informed, or were experts in a subject, and changing the default position in that. Another reason that you sometimes get flaws is what's called hyper-discounting of the future, where you bear the costs today of something, but the benefits are so far off into the future that it's really hard to sort of make that. I put flossing into that category, in the sense I love to floss, but with my children I can see that, when you talk about their teeth 40 years from now, they're engaging in some pretty hyper-discounting. They're talking about climate change. We might not even be around in 40 years. So there's a real hyper-discounting they have of the future.
When I thought of this topic, I immediately jumped to a meeting that took place in New York City several years ago. As public companies, we address Wall Street, and we have these meetings where we have to go to these investor conferences, and it's like a beauty competition. We say, invest in our company, you'll get a better return than if you invest in someone else's company. And in some of these events, they also have luncheons. And there was a lot going on in healthcare at the time. It must be, there's always a lot going on. But 7 or 8 years ago, there was a lot that Wall Street was really interested in, a particular topic. So Dr. Sullivan's successor, a couple successors later, Secretary Thompson was there. And he was going to address the audience. And people expected him to make a major statement. And the room was packed. These luncheons normally don't get a lot of people, but there must have been 1,300 people in the room. And I happened to be sitting with Secretary Thompson at his table, and his aide brought him the speech that had been prepared. He looked at it and he said, "Take it away." Secretary Thompson was going to be speaking on how to reduce the cost of healthcare. So everybody was ready for this major discussion and his major remarks. He got up and he said, "Let me answer the question. It's all about wellness. It's about reduced smoking." And Dr. Sullivan was one of the first secretaries of health to actually go out and talk about taking on this topic, reducing smoking. It's about eating the right food, and it's about exercise. And he sat down, and the audience was stunned.
And it's really hard to separate out the tapestry of oral health from medical health, because if you have Parkinson's, it affects your oral health, and there are a number of chronic conditions that impact it. On the other hand, over 50% of our members have at least one chronic condition, and many have 2 or more. And they're on a number of medications, and medications affect oral health. I saw yesterday in the New York Times a study on SSRIs that are used to treat depression. And 9% of people 65 and over have depression, which I think is a low estimate. I think it's higher than that. But if you are on an SSRI, it really leads to a significant failure rate for implants. And if you look at antihistamines, diuretics, they lead to dry mouth and difficulty swallowing. So for our population, there's no way to separate medical and oral health.
But my point is that after yesterday, I, like John McDonough, like others of us who are outsiders, was pretty blown away by the presentations of the data. I found them very compelling. And so I too now consider myself a convert to the cause and the so-called economic imperative, which quite frankly is a care imperative.
Let's start with money. Whose money? Almost all the money in healthcare, whether it be oral health, mental health, physical health, almost all the money comes from one source. One source. And it's important to remember that. It comes from wages. People buy a plan with their wages. People go to the dentist or the provider and sometimes have to pay out of their wages for the services they get. If they have an employer who gives them benefits, I assure you, as an employer, we consider that part of your wages. And out of your wages, you pay taxes. You know that line that says Medicare? So essentially the money comes from wages, and that's actually something we tend to forget when we get in a symposium like this, that it comes out of people's pockets.
So not only is the dentist changing, the dentist of today changing, but consumers are changing. This was a study done by Deloitte. It essentially says that about 22% of patients now, consumers, they call them, patients, are compliant, content and compliant. Another 78% are out looking for something new. And they're more demanding on their providers.
Now, what's happened in healthcare and what has historically happened in higher education is almost all of the innovation has been on that trajectory. How to make good products better that we could sell for higher margins to our best customers. There has been, until very recently, almost no energy around making things more affordable and accessible. And the reason why this has happened, is my sense, is that the insurance industry, Medicare, and our caregivers see two ops. One of them is, how can we enable people to be able to afford health care? The other option would be, how do we make health care affordable for everybody? And there has been very little energy on that second option. Rather, we will help you help you be able to afford health care in some way or another. The same thing has been at work at higher education. It is, how can we help everybody be able to afford higher education? And so we provide to them Pell Grants, and then another Pell Grant, and then student loans and more student loans, so ostensibly you can afford higher education. And it's only been very, very recently that there has been any attention targeted at, gosh, could you make healthcare affordable? And then who decided that dental care ought to be provided independently of medical care? Because in many ways, especially for children, health is health, both independently determine health, and yet somebody in the past decided that they ought to be kept separate. And so my sense is that health care, body health care, and dental health care essentially arise at the same point in time and space when you're trying to help us stay healthy. And that's why I would predict that what Bruce is talking about, that we want an initiative to pull these things together, actually is not a stupid idea. Somehow somebody in the past decided they ought to be separate, and we don't need to bow down to that any longer. That's essentially what you're saying, right, Bruce? I am much more eloquent than you.
We will be discussing a whole host of options for this conference, from publishing of proceedings to making some available in Inside Dentistry. Dan Perkins has kindly said that he might do that. I hope it's been an informative conference for you. It certainly has been for me. I will only end by saying, in line with what you suggest, I grew up in healthcare, and one of the most impressive things I always remember coming from New York, in New York, when someone got admitted to the hospital, they had, let's say for surgery, they had the name of the surgeon, but they also had the name of a physician on the door. And I always thought that means surgeons couldn't take care of any medical problems. And when I came up here and started an internship at the MGH, I was really impressed that surgeons admitted their own patients and only their names were on the door, okay? Now we have emergency room physicians, hospitalists, intensivists. It goes on and on and on and on, and I always wonder, how is any physician going to really know their patient if they don't see them when they really get sick and go in the hospital? To be continued. Thank you very much.